Her genetic report did show a RET mutation, which is an RET variant. This is on the specimen. What do you think of that in the face of a systemic RET negativity?
So 2 comments. One, when somebody tells you they have a negative RET gene, you actually have to see the report. I saw one last year, and the RET gene they had tested was something called RHET. It's a pediatric thing, and the endocrinologist thought he ordered a RET gene, and it was the wrong RET gene, and she had MEN2A. So looking at the source documentation, making sure it really is genetic. And then over the last several years, we've learned that there are mutations within the tumor that are not germline. And so finding a 634 or in some of the really aggressive medullaries, the 918, what would have been an MEN2B mutation, it's not in the rest of the body, it's just in that cancer cell. Those are really important to know now because we have RET targeted therapies. So we used to say if you have a sporadic medullary, it's not RET, we can't use any of those RET inhibitors. And now we know, particularly some of the aggressive medullaries, they don't have MEN2A, their body is fine, but in that tumor, there's a RET mutation, often 918, many times 634. So it doesn't do anything for her right now, but if we got in the setting of distant metastasis, it would bring RET inhibitors into play with her, even though she was a sporadic medullary. So important to know, we call this somatic testing, somatic inside the tumor versus germline. So interesting, and you file that away. This lady's never gonna need it, but if you were dealing with a more aggressive one, it would.